People who train with me will tell you I love doing manual decompression.
Yes.
Welcome back to PedsCrit. I'm Zach Hodges, a pediatric ICU fellow from University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow in Washington, D.C.
Alice, will you tell listeners what we do here at the PedsCrit podcast?
Absolutely. PedsCrit is an educational interview podcast. We are looking for our attendings from around the country and sometimes around the world to give us their best bedside teaching spiels about their favorite topics.
And who do we have today?
Today we have one of my attendings, Dr. Mekela Whyte-Nesfield. Dr. Whyte-Nesfield is a critical care attending at Children's National Hospital in Washington, D.C. She did her MD at her home country of Grenada at St. George's University. She then did her fellowship in pediatric critical care at Penn State Health Children's Hospital in Hershey. And she is interested in the role of parent and child PTSD development. She even ran a multi-center prevalence study during her fellowship, which is incredible to us thinking about it now. But beyond that, Mekela is the person you want to help you adjust vent settings on your sickest asthmatics, broncholytics, ARDS, really anyone that you're having difficulty ventilating or oxygenating. We are so lucky, and I am so excited to have her for this episode.
This is part one of our two-part series on invasive mechanical ventilation of asthma patients. Such a rich episode with lots of practical tips for a low frequency, but certainly a high risk scenario that we find ourselves in the PICU.
Yes. Let's get right to the interview. Mekela, thank you so much for joining us today. We've already included your intro at the top of this episode, but can you tell our listeners who you are and what you enjoy outside of medicine?
My name is Mekela Whyte-Nesfield, and I am born and raised in the beautiful island of Grenada in the Caribbean, for those who don't know. So yes, I'm not adapting well to this current weather change. Things I love to do are mainly outside. So lots of hiking and exploring are things that I love to do by myself or with my beloved family, which is my number one priority. I have a husband and two rambunctious boys. When I'm not doing that, my second love would definitely be the critical care unit. I am a researcher, but my first love is critical care on the clinical side for sure.
Yes. Zach, if we ask Mekela about how she feels about New York beaches, we're going to have to get into a fight. So I'm going to skip that and ask...
Let's not even go there. There are no beaches in New York.
So my second question for you is, how do you recommend current PICU fellows improve their vent management skills?
Okay. I'm a very big fan of the West book. It was introduced to me in my second year of fellowship by one of our own fellows from here, actually, Alice, by Dr. Bob is what we used to call him. Aww. And Robert Kavanaugh, definitely went through that book with me, kind of like a journal club review. And it just opened my eyes to a whole new world and thinking about ventilation really from the physiologic standpoint instead of just, I know how to do this. I know I've seen this before. So I always recommend that fellows and residents really take the time to understand the physiology, understand the complications that can happen from intrathoracic relations with the heart and what exactly you are to expect. Because in the ICU, while people think of us as being reactive, the blood pressure drops and we do something, how we should be thinking is, what are the things that can go wrong so that you're prepared for that? So if the blood pressure drops, it's, I expected that. And you already have the things prepared.
Oh.
So fundamental to everything that we do.
Mm-hmm. Definitely.
We'll be sure to leave a link to that in our show notes for this episode.
Yes.
Shall I give us the case and we'll get started on our topic for the day?
Would love it.
So your patient is a 5-year-old, previously healthy. He has a history of asthma, and he presented in status asthmaticus secondary to rhinoenterovirus. He was intubated in the field, actually, for increased work of breathing, respiratory failure, and transported via ambulance to our PICU. On arrival, you hear that he did not tolerate the transport ventilator very well, and he was actually being bagged the entire 40-minute transport. So if we just step back from the chaos for just a second, what, if you had a patient in front of you, they're not intubated quite yet, what would actually make you intubate an asthmatic?
So the age-old question, right?
Yeah.
Let's start by saying first, we hate intubating asthmatics. And so to intubate an asthmatic, you really have to be in an extremist situation. So one of the things that we talk about a lot with asthmatics that would make you feel like you need to intubate would be neurostatus. So if you have an asthmatic who is no longer able to communicate with you, not just from a work of breathing, but they're actually obtunded, you are way past the time when you should have intubated. So that's the biggest one. Then you look at work of breathing, yes. Asthmatics tend to breathe shallow and fast, right? And so if you're really seeing them starting to slow down without improvement of your air entry, or something called silent chest, where you're hearing them inhale or not hearing them inhale, and you're not hearing anything coming out, that's a sign that, you're definitely in trouble. And if you've tried all your treatments, it may be a sign that you're getting near where you would need to intubate. And then, yes, you want to look at additional information. So if your hypercarbia is to the point where they're no longer able to compensate, it's usually with asthmatics, unless it was an immediate trigger, like someone sprayed them something in their face or something, they've been getting sicker, right? For a while. Their body has already been compensating from a bicarb standpoint, because it's usually more than 4 to 6 hours that they've been getting worse. And if they're not able to compensate anymore and your gases are getting down to the 6.9, 6.8, and you have already tried your treatments. So the reason I say that multiple times is because sometimes you may be in that situation where the patient is not obtunded, they're working hard, or their chest is silent, and you can put on a BiPAP machine and you can give them their albuterol and you can give them epi and you can give them terb and Atrovent and mag and actually break them without having to intubate them. So you really need to take into account, if they're not obtunded, what have they gotten? If they are obtunded, it's already time to intubate.
So thinking about these patients, they are so interesting in their acid-base abnormalities because it seems like they can tolerate an extreme amount of hypercarbia.
Yes.
But they also, not uncommonly, have really high lactates, maybe secondary to all the albuterol beta agonists they're getting. Maybe there's some oxygen delivery issues. It's hard to really know for sure. Do you, I imagine what you're trying to tell us is you look at the patient, you look at their mental status, and you maybe would set aside the blood gas information if you feel like their trajectory had a chance to improve. Is that right?
Yes. And even if you have a high lactate, I totally love that you bring up B-type lactic acidosis, because that's very possible depending on where they are in their treatment, right? If they're sitting there on terbutaline and albuterol, they're going to potentially have some beta-type effects, because now you're not only looking at the albuterol going through the airways, you're looking at it going through the bloodstream. So they're definitely getting it. You also have to realize that, one, are you so obstructed that you're impeding blood flow, right? Or is your beta effects so bad that you're impeding their blood pressure with a widening blood pressure and low diastolics? Those things need to be taken into account. Do you need fluid? Is that going to help your lactate? How bad have they been at home? Are you talking about a dehydration effect as well? And so I don't like to think about, this is just work of breathing creating lactate or hypoxia creating a lactate, but really the overall picture of the patient. And then to bring up the hypoxemia debate, if you have a pure asthmatic and they went from satting okay to now being hypoxic, you're in trouble, right? Because asthmatics, a pure asthmatic, not like the one in our case who does not have a diffusion issue, but really it's just an air entry issue. Now you're severely hypoventilated, leading to significant hypoxia. And what are your lungs going to do with that is it's going to cause some vasoconstriction on your vascular side and worsen your VQ mismatch and all of that. So you really need to think about, okay, what's going on here that's causing them to be hypoxic if you have a pure asthmatic? And if it's really just hypoventilation and you've given all your therapies, then you need to start thinking about intubation as well. So unfortunately, like all things in medicine, there is no hard, fast rule. And high lactate does not necessarily mean you need to intubate right away. You need to see where it's been, where it's going, and think about the reasons that could have caused it.
And it also, this sort of flies in the face of the classic teaching that an asthmatic, when you get a gas, you're at the med alert, deciding about intubation. The asthmatic CO2, we're classically taught, should be low because they're compensating. But because of the complications of intubating an asthmatic, you might let that CO2 climb, especially if you still have therapies to give in a little bit of time. You expect a reversible disease process.
Definitely. If you have a pure asthmatic or what you believe is a pure asthmatic, myself and a lot of my colleagues will tolerate some hypercarbia. I have had kids with silent chests that, you just throw all the therapies at them and they break and you spare them the intubation. And it's always going to be the art of medicine really helping you decide which one. Like, have you given them ketamine? Have you given them aminophylline? Even Atrovent, people tend to be like, Atrovent's not going to help you. But when you think about it, it's a different receptor from your classic beta agonist. And so I will definitely throw that in there. Have they got an epi? Have they got an terb? Have they got an mag? Is really going to help you. And so we have had kids who have had higher CO2s that we've been able to break. And then the last one is, have you tried BiPAP, right? So if the kiddo has not been put on BiPAP, you need to slap that on right away and see if that PEEP is just going to help distend those airways enough that you're able to get better air movement.
All great stuff that will continue to impact here. How about I walk our case a little bit forward?
Okay.
So your 5-year-old patient, asthma, rhino positive, intubated in the field. They're being bagged on 100% oxygen. Saturations are in the low 90s. You transition them to the servo. You look at the end tidal, it's triple digits, super high. Put them on the monitor. They're obviously tachycardic, tachypneic, but their blood pressure is normal.
Okay.
Tell me your mental model. What do you want the next 30 minutes to look like for this patient? Labs, x-rays, what do you want to do? And then what is your kitchen sink for asthma? What does it include?
Okay. So yes, you already stated some of the things that I would want to know, like, okay, what has this patient gotten, right? And then 2, what were we trying to do on the ventilator that the patient was not able to tolerate? Is the patient sedated and paralyzed? And then what are the things that I need to be ordering because I'm thinking ahead, right? So that proactive type thinking, if this doesn't work, then what's next? I do want to have some information on just your physical exam of whether the patient looks hydrated or not. And then in the ABG, if we can throw in some chemistries, that would be great. The hemoglobin, that would be great. The hypoxia, because this case is a little mixed and we kind of have a diffusion injury probably as well with the rhinoentero, doesn't bother me as much. But I want to know if this kid's been bagging on 100%, are we dealing with a diffusion injury and hypoventilation creating this situation? And then my very first thing I would do is change the vent. So what are the vent settings on? And I need some information from the vent, whether the patient is exhaling all the way, which is a big deal. In asthmatic, what your IT ratio and what other things have been going on.
Oh, perfect.
Let's set aside the vent management because it certainly will be the meat of our conversation. Just some highlights of your personal practice, if you don't mind.
Okay.
What do you choose to sedate these patients? I hear about ketamine being bronchodilatory. Do you paralyze all these patients that look this sick? What are your practices?
So ketamine for sure. If you're going to intubate an asthmatic, why not use ketamine? So when I think why not, I think, okay, am I thinking that we're still going to have some potential catecholamine surge depletion, which is what you worry about with ketamine? So usually in a kid who's recently been sick, you use ketamine, you're going to get tachycardia. But if you have a kid who's been sick for a long time, there's a possibility that you can have catecholamine surge depletion, and therefore you may end up with some hypotension, right? Which you don't necessarily want in this case. And then I do paralyze my asthmatic. The one thing that would give me pause is the same for any patient you're going to intubate, okay? Do you think this is going to be an easy airway? And if you don't, for whatever reason, whether the kid has Piriben or some other issues, do you have the capability of getting an airway quickly, right? Because what you don't want is a paralyzed asthmatic that can't compensate and now you can't get an airway, right? So those are the things that I tend to think about off the bat. Other things that I think about when intubating an asthmatic is, do they already have evidence of air leak? Because then I'm thinking, this intubation is going to make it worse. And then my mind's already trickling down to, but I won't say it yet, the other things that we may need to do for someone with air leak syndrome. So those are the things that kind of make the chest x-ray helpful and beneficial in this aspect if there's air leak that you can't see just of yet, or if you have a huge pneumothorax, like, can you listen and are you having silent chest on one side versus the other? Those are things that I tend to think about. So to answer your question a little bit better, when I'm looking at this patient and I'm like, okay, we have an asthmatic, what are the things I'm going to do right now? It's get the meds into him. If I think he needs to be intubated or he's already intubated, how am I going to ventilate this patient? And is there anything precluding me from doing that in my basic vent management for an asthmatic? And that would be pneumothorax, air leak syndrome, those things.
No, thank you.
So one quick follow-up question.
Yeah.
In your practice, do you routinely use MAG, TERB, continuous albuterol, aminophylline, all the above, or do you have preferences?
So I do use the basic ones, which is, as you mentioned, albuterol, MAG, TERB, epi. Epi is really helpful in cases where there may be an allergic component as well. are the ones that we tend to use off the bat, or the ones that they've already gotten at the outside hospital before they even get to me, right? Because most ERs are really good at trying to break asthma. The big ones that we bring in the ICU is really going to be like your turb drip. Atrovent is given downstairs, but also your aminophylline, your bolus and your drip. And so this is where I kind of think of I don't think of aminophylline as a first line, even though it's a great bronchodilator. It has some effects that are like less intriguing. So if I have an asthmatic who is otherwise healthy, good urine output, and kidneys are intact, and they're on the unit, I will definitely think about aminophylline. If I have a mixed case, which I had just the other day, where, you have Coca-Cola color urine and not much of it, and this kid is probably super dehydrated for some time, then I try to at least get them hydrated up, see some better urine, see the labs, to see my creatinine and BUN before I just load them with aminophylline, because you don't want to add the ill effects of aminophylline like seizures to the picture. And so those are my bag of tricks in terms of medicine. People who train with me will tell you I love doing manual decompression.
Yes.
Right. And so, yeah, it's one of the things that I use definitely for asthmatics, but even for kiddos who were just you see stuff in their airway, you hear it and you're not able to get it out. Manual decompression during suctioning for those kids. But for an asthmatic, especially this one who's not on the vent yet, you pop off the bag and you just manually decompress that chest. Almost instantly, you'll get bigger volumes in, and you can see it sometimes on the vent, and you'll have more ventilation for a little bit of time. So that sometimes can really buy you some time while you're waiting to get all of your things in.
Yes. This is Mekela, I was telling Zach that one of our fellows found this case series published 2021, Journal of Pediatric Pulmonology, of a hospital in Jerusalem where they talk about their manual decompression moves as hypercarbic asthmatic, not intubated yet. You sedate with ketamine and midaz. You squeeze the chest for like an hour. And in these 5 cases, I know.
You mean with breaths?
Yeah, with each exhalation.
Okay, good.
No,
like,
you just hold it down there. They tolerate it well, and then they don't need intubated.
And then they go to the morgue.
No, with each exhalation, and it's like seen as almost a maneuver, a procedure, and so I think it's really interesting. But you use it anytime, right? Like you use it in the clinic if you need to squeeze a wheeze. You use it in the ER if a kid is not tolerating the BiPAP well. And you can use it in an intubated patient with each exhalation just to capture them.
Yes, with each exhalation. You don't want to be decompressing their chest while they're trying to get a breath.
Yes.
So yes.
So tell me, what does this look like in your practice? Is this just a senior RT pressing on the chest with each exhalation on BiPAP? What does this look like for you?
So for me, if they have a tube already, it means just detaching from anything, leaving the tube in and doing it. If they're on BiPAP, yes, it's really hard to do if the patient's like breathing like super fast. And so sedation is helpful. But I usually take the mask off. So it'd be one of those times where, because I don't want to have a breath be trying to come in while I'm manually decompressing. And manual decompression is not like 1 or 2 seconds. I at least hold it for like 5 seconds and really get that breath out. And so I would just pop off the mask. If you're bagging, you pop off the mask and you do it and try to get as much air as you can out. I hate to say this because I am female, but I also find that sometimes with really big teenagers or like semi-adults, I'm not strong enough. And so making sure that you have someone, if you're not getting it done yourself, making sure you're leveraged okay. I have gotten up on a bed and done a manual decompression just to get myself in better position. I have totally asked my male colleagues, hey, I need you to do this. This is how we're going to do it. And you hold at the rib cage. And when I take off this mask, whatever, you're just going to push in a downward and upward movement, downward into the chest, to the back, and then try to squeeze up in terms of the lungs themselves.
Yes. We had in the past year, intubated asthmatic teenager. And when we came in the morning, one of my co-fellows who is a man was like, I was giving a bear hug with my full body to try and decompress his chest all night.
Yes.
And we, did well, helped him. But yes.
Yeah. You just have to accept, you got to do what's right for the patient. And if that means somebody else doing it, it means someone else doing it.
Yeah, I feel like I'm missing out so much. I'm 2 years into fellowship and haven't done a manual decompression yet. I feel like I need to come hang out.
Yeah, let's come to DC.
You do need to come hang out.
So much fun.
We have lots of asthmatics here, so you definitely need to come out.
It is a swamp. So let's go over to the vent. So your patient is transitioned to the servo, entitled to high to read, still paralyzed from the transport. You're on pressure control, pressure support, 35/10 with a rate of 18 and an I time of 0.8. You're pulling 1 to 3 per kilo, and ABG is obtained in 6'8", 180, 67 minus 4.
Ew.
So
what do I do?
How do you even start?
So we know all he's gotten, and I think we said methylpred, right? Because I just realized we haven't brought that up.
Yes, you got it ordered.
Okay, good. Because that's a time issue, right? You want to get that in as soon as possible because it takes like a good 4 to 8 hours to work. So now my attention is definitely to the vent, right? So still sedated, still paralyzed. We have good blood pressure. How am I going to get breaths into this kid is what I'm thinking. So the first thing is, since we have a kid with rhinoentero, I need to know what his plateau pressure is, right? What are the alveoli seeing? Because that's where I'm going to be concerned about barotrauma. And if they're not seeing much, like we're talking about less than 30, then we need to go up on that pressure control, right? And so we would do a plateau pressure with an inspiratory hole. I do these in volume control just because they are more accurate. That does not mean if a kid is in extremis and I don't think he'll tolerate switching over that I won't just do it in pressure control. It still will give you data, right? And so if you have a big difference in your PIP to plateau, great, this looks like more asthma than the rhinoentero, and you're going to dial that up. And when I say dial it up to where you feel uncomfortable, because what you're looking for is air entry, right? So 1 to 3 is not going to do it. And then with dialing it up, since we're in pressure control, the way that you increase breaths also has to do with your I time. And so you're like, what are you talking about? We need short I time, long exhalation time, classic asthma therapy. And the way you get that is that rate is absolutely too high, right? So we need to bring that down. Anywhere from 10 to 12 is where I would be aiming for a kid this age. And so say we bring it down to 12. When you're looking at 60 divided by 12, that's 5, right? So you're trying to get your IT ratio anywhere from 1 to 3 to 1 to 4. And so you go to 1.2, you're still within that range. And that allows you in pressure control the time to actually get the breath in, right? Because pressure control, you're going right up to that pressure and then your flow is going accelerating, right? And so you want to give time to get that air in. And so I would do those things and then see if he is completing his breaths. As with everything in medicine, you have to look at your intervention and see what results you're getting, right? So if you decrease the rate, increase your I time, and go up on your PIP, let's say we start with 45, right? If you're, I don't know what our plateau is, but say your plateau is like 20, say we go up to 45, then you're saying 38 to 20, there was an 18-point difference. So now you're going up to 45, you're looking at an 18-point difference still, right? With what your alveoli are seeing. And then watch your tidal volumes and watch to make sure you're exhaling.
Nice.
Okay, Mekela, lots of great practical information about setting up the vent. When you're at the bedside, what actual mode do you choose on the ventilator for these patients?
Okay, so I'm going to give you a little mix. Personally, my choice is pressure control, pressure support. The reason is mainly for the setting that I'm in, right? One, when you use pressure control, pressure support, you're setting the pressures. The vent is not going to alarm all the time for high PIPs. Once you change the pressure alarms settings. The caveat to that is that the vent is also going to have a wide range of tidal volumes or minute ventilation before it alarms. So what I do is usually talk to my RT, I'm going to be good, and have them narrow the range for minute ventilation so that I'm alerted when there's a change with the bronchospasm, right? Because what you don't want is you're on a PIP of 50. Yes, I have been there before. And the patient breaks and all of a sudden their tidal volumes are like 12, 14 per kg. And you're like, oh my God, volume trauma, horrible. Right. And so your nurses, they're too busy. The kid is sick and they cannot be looking at your minute ventilation the whole time. What's going to alert them is your low CO2, which by that time they've probably been having volume trauma for a little bit. And that's it, right? So you want to make sure that you have control of what your minute ventilation is going to be. And the way to do that is to set your alarms so that the vent will sound it out and the nurse will be like, oh, what's going on? The second thing is I do know fewer, but I do know colleagues that use PRVC or volume control even. A lot more adult colleagues I've seen using volume control. And so the reason they're saying is, listen, we're going to have high PEEPs regardless. When I set that PIP to 50, it's the same high PEEP, right? And this allows them to check their plateau pressures and everything more easily, and you get guaranteed delivered volumes. So the caveat for that is that if you don't change the alarm settings for your PIPs, it's going to be alarming the whole time. And everybody's going to be very paranoid about the possible barotrauma that could be going on for the patient. And so when you're doing that, you should change your alarm settings. The good thing about volume control is, hey, when your bronchospasm's gone, you don't have to worry about anything. The PIPs are going to come down automatically. Life will be great. You have a guaranteed volume that you're setting, and you're not worried about volume trauma whatsoever. The other things are the same though. I would, even if I'm using volume control, a lot of people use zero PEEP. There's not anecdotal evidence that tells me 100% that is the best thing to do. And even with my adult colleagues, they're like, yeah, if it's not working, we go up on the PEEP. So for me, I would still use PEEP. You set your volumes, and you want to give decent volumes for asthmatics. So you're not going to be doing your 4 to 6 per kg. You're more looking at like 8 to 10 really is where you're aiming for. And you set those, and you see where your PIP is, and you set your alarms and see what happens. And if you're on the other side with your pressure control like me, you're going to set your PIP, and then you're going to set your minute ventilation alarm so you're alerted when things change. And that gives you a better picture of what's happening. It also alerts you when you change your alarm settings or you make your minute ventilation more narrow. It also alerts you when your bronchospasm is getting worse, which is even more concerning, right? Or your overall compliance is getting worse.
Yes. You need to be like literally alerted. Volume's too high, volume's too low, because it's really easy to miss.
Exactly. And you're not going to see it until you get that gas and you're like, ah.
Yeah. Or you walk over to the vent and you're like, what happened?
What happened? Yeah, exactly. Yeah. Exactly.
And those same fundamental rules still apply. Even in volume control, you still want your plateau pressures below 30.
Yeah, you do if you can.
Yeah.
And if you can't, for whatever reason, which is usually patient dependent, then you try to be as close to that as you can.
Question about the respiratory mechanics. So you have this patient in pressure control ventilation. They're only getting around 3 per kilo total volume. You want to get an accurate plateau pressure. Do you put them in volume control 3 per kilo? No, you don't. You put them a little bit higher, right?
Yeah.
How much of a difference between PIP and plateau would you want there to be to infer that this is significant obstruction? Like 2 points or 10 points? I imagine that you would not push things where your plateau pressure was above 30. Is that right?
No, we do not like plateau pressures above 30 because that is classically where you start seeing barotrauma. And so we think about that in everything, right? Like when we're ventilating kids with just rhinoenterite, we're like, ooh, their PIPs are above 30, like they're definitely still really sick. And so we try not to put our plateaus above there. I have had cases where I've had to because it was a mixed picture, kind of like this kid. So the kid had like really bad asthma and ARDS. And so there was no way I was going to get anything with just plateaus of 30. Then the other thing that we try to do in talking about where you would set them if you're switching them over to volume control is, I would aim for something like at least 6 to 8 per kg. Because if you're thinking of pure asthmatic, we're not doing ARDS therapies where we have to do super low volumes. All that's going to do is get you a really big PIP and make your RT look at you strange. Like, what are you doing? So I usually change the alarm settings when I'm doing this so that everybody can leave me alone. And then I do it and see. And you're definitely aiming for anything greater than 10. But usually in an extreme case like this, you're going to be way above that, right? But when we talk about, okay, classically, are you having any type of airway obstruction? If you don't have a PIP to plateau of greater than 10, something else is going on, right?
Yes. And this is the perfect, this is, in my mind, ventilating an asthmatic is the perfect example of static versus dynamic compliance.
Yes. When we think about dynamic compliance, we're talking about, okay, what's going on in the full airway, right? Like everything. Do you have upper airway obstruction? Do you have some kid biting the tube? When I think about dynamic compliance, that's usually what we're dealing with all the time, right? With our kids who are intubated, or, I mean, not intubated too, but we think about it more when kids who are intubated. Really, you're looking at the resistance throughout the whole airway with dynamic compliance, right? That means whether your kid is biting a tube, whether you have upper airway obstruction, whether you have airway obstruction lower down, and then, of course, your alveoli, whether you have diffusion injury or whatever the case may be. With static compliance, the reason that we look at your plateau pressure is that's really the pressure that is being exerted when there is no flow, right? So you have completed the flow stage of your breath and you're holding it. That's why you do an inspiratory hold to where no more air is flowing through your upper and lower airways. And this is just the pressure that you're using in the alveoli. So it really gives you a picture of what's happening when there's no flow. And that's why we call it static versus dynamic compliance. And so the equation really just changes your PIP pressure to your plateau pressure to give you the different answers.
Yes.
So to simplify things, maybe the plateau pressure, the static compliance, maybe that's a marker of the lung parenchymal injury.
Definitely.
And then
Definitely.
And maybe the difference between the plateau and the peak, maybe that gives us an idea of how bad the airway obstruction is.
Couldn't have said it better, Zach.
Your equations are dynamic compliance is tidal volume divided by PIP minus PEEP. That's your dynamic compliance measure of everything. And static compliance is tidal volume divided by plateau minus PEEP.
Correct.
And then the difference between your plateau pressure and your PEEP is known as the driving pressure.
Yep.
Okay. And thank you for listening to this episode of Pete's Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Pete's Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Pete's Crit laptop stickers. And if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.